Assalamu alaikum and good morning to everyone. I would like to thank the organizers for inviting me to give this talk at the Masterclass. I will share my presentation now. Okay, right. I hope you can see the screen. Okay. Okay, I've been asked to speak on this topic, not all seizures are epileptic. What I'm going to do is share 5 case presentations in the form of videos, a brief history, and then some discussion. So the first case is a 38-year-old right-handed woman who was previously well. Her first seizure attack was 12 months previously. She had 6 months of worsening seizures, admitted to hospital acutely following a prolonged seizure. And during admission, she had daily attacks, sometimes several times per day. And she was on 4 anti-epileptic drugs as listed here. She had no auras. The onset was abrupt. This was an attack recorded in the lab. It's using an infrared camera, so it is black and white. Just look at the attack and notice all the movements of her body, head. So you can see the movements, yeah. So she's jerking. Stop. I won't make further comments until later. It's another jerk. There'll be another one after this. It was about 5 minutes to end completely. I just want you all to think about whether these attacks are epileptic seizures or not. Okay, so are they? Well, they are not. What she had was pseudo-seizures. A pseudo-seizure was recorded in the attack in the lab. And these are some of the features we use to differentiate pseudo-seizures from epileptic seizures. In a pseudo-seizure, or nowadays called non-epileptic attack disorder, the attacks are not stereotyped. Firstly, it depends on the presence of an audience. If there's no audience, they won't have an attack. It's a waste of time. Second thing is the relevance and importance of the audience. If the attack, if there's no audience, no attack, and if the audience is just the parents or a sister or brother, they will probably just have a drop attack, like a faint or some jerks. But if the audience is a consultant, especially in epilepsy, then the attacks will be more dramatic. It changes with the audience. These attacks also occur rarely in sleep because the patient also wants to sleep. And usually there may not be a sleep partner. If there is, they may have an attack by waking up the partner either by a scream or a movement that would hit the bed partner. The third bullet, sequence of events often build up slowly and waxes and wanes, as was in the video. So you see the jerks, several jerks for about maybe 15 seconds, and then the patient stops jerking because she was tired, and then she jerks again, and then start, and stop. So this is called waxes and waning, waxing and waning of the jerks. Now, pelvic thrusting and head rolling are common features. Just look at this second video. You can see this man opens his eyes to see whether he has enough people in the audience. And then he will start having this body movements. Basically, he's rocking his pelvis, thrusting up and down, made easier by the old spring bed in Hospital KL. And this man would purposely bite his tongue and also sometimes would wet his trousers with urine, but usually no, he doesn't do that. And he was given some medications by our medical officers, but he never took them. So he's stiff, and this will go on for several minutes. It's quite effortless. The next patient is a younger patient, a girl. As you can see here again, she has head rolling. Now, head rolling from side to side is never a feature of an epileptic seizure. In fact, she's saying, no, no, I don't have any epilepsy. You guys are really stupid, you know? So please help me, please help me. I don't want these attacks. And she has some jerks in the leg. The left hand will come up with some flailing around, as you can see there. So these are not multifocal seizures as diagnosed by some medical officers at that time. Okay, right. So this will go on for a bit. I'll just stop that there. The clonic movements, the fourth bullet here, would lack rhythmicity. So in an epileptic seizure, the jerks would be small amplitude and fast, and then they become bigger amplitude and slows down. So that's a typical rhythmicity of the clonic phase of a tonic-clonic seizure. And in these cases, there's little or no post-ictal phenomena. They don't need to have that. They want to get on to find out what the diagnosis is. And one must remember that 30% of patients with epilepsy actually have additional pseudo-seizures. So if you record one attack in the lab and it's a pseudo-seizure, that's not the end of the story. You have to investigate and find out more. Maybe more recordings are needed. Right, so this is another attack. This patient, courtesy of Queen Elizabeth Hospital in KK. So this patient again has the head rolling, quite common. She stops there. So there's waxes and wanes as well. And there you go, head rolling again. No, no, I don't have any seizures. So these are quite irregular arrhythmic attacks. So these are pseudo-seizures as well. So pseudo-seizures or non-epileptic attack disorder are more common in women. They usually start in adolescence. The secondary gain may not be obvious initially, right? And the psychological complex may be more, psychological basis may be more complex, such as sexual abuse in childhood. And the fifth bullet here, history of overt psychiatric illness is common. The second case is an 18-year-old right-handed woman who had 3 episodes of blackouts in the preceding 2 years. The first attack occurred during a school assembly in the morning, coinciding with the beginning of her menstrual period. The second attack was during a band concert at about 9 p.m. The third one during her speech presentation, again coinciding with the beginning of her menstrual period. She would complain of visual blurring and things becoming distant just before the attack. She would have ringing in the ears sometimes. In an attack, she would appear dazed, pale, she would fall, and the whole body becomes floppy. She would have jerky movements, including of her mouth, and she would bite her tongue. She bit her tongue in one episode, which was the first one, and she became incontinent of urine in the second episode. She was immediately responsive after the attacks. So this was one recorded. This is from Prof. Dr. Chong Wong in Sydney. So thanks to him. So this girl, you can see now, this becoming floppy. She would just slump in the chair. You can see the registrar trying to take her blood. She's going to slide down the chair a bit. You'll see the jerking movements in a minute and stiffness. Here comes stiffness. And she'll have some jerks. Right, so yeah, she's regaining consciousness now. That was less than a minute. So that's the attack. So was that an epileptic seizure? Okay, just think about that. Think about the answer. We'll discuss this in Q&A if there are questions. So what she had was a vasovagal attack, or sometimes known as simple faints. Now these attacks usually have an identifiable precipitating factor, such as getting up quickly, prolonged standing, like in an assembly like she had. This is quite common even in our country. Sometimes in hot and stuffy weather, crowded rooms, painful stimuli like taking blood in her case, frightening or unpleasant scenes like in a road accident, right? So there's usually an identifiable precipitant. These attacks are usually preceded by lightheadedness, sometimes nausea, ringing in the ears, and the vision going black. They become pale, sometimes flushed. Incontinence is not uncommon, so this is not specific, just like the myoclonic jerks and tongue biting, not specific for epileptic seizures, may occur in vasovagal faints or attacks. Automatisms may occur. I'll show you a video after this. And there's no positive confusion or drowsiness usually. They become immediately responsive, like in the video in Sydney. So this just to show you this video of an experiment done on 5 German medical students. They were all asked to do a Valsalva maneuver while squatting, and then they all had to stand up. And when they stood up, everyone had a vasovagal attack. So just watch this video, different type of clinical phenomenon. So this in the first attack.
Falls out stretched superficially.
So it falls down. It's quite a bad fall.
And again,
stiffness. Second patient, second student had some jerks of the upper and lower limbs.
These can be so prominent
may actually look like epileptic seizures or tonic-clonic seizures. And this one a bit more prominent. And to the bystander and observers, this might actually look like an epileptic seizure. I think you would agree with that. And sometimes the attacks may look focal, like this guy here. The right arm is stretched, the head is turned to the right. You may think this is a focal seizure. And this last one is classic. This man ruffles his hair, so it looks like an automatism in temporal lobe epilepsy, which is not the case. So in all these patients, there was no post-ictal confusion or sleep. They were immediately responsive and they recovered very quickly. So these are vasovagal attacks. Right. So blackouts are quite common. When they present to the emergency department of primary care, epilepsy only accounts for about 8% of cases when you see someone with so-called blackouts. A lot of patients the cause is unknown, so it's about 34% here, which is later on found out to be vasovagal attacks actually. But the majority of cases, 55%, due to cardiovascular cause. So around about 20% may actually be due to vasovagal attacks. And this research or a study was done and published in the journal Heart. It's not in any neurological journal. So when someone comes to the emergency department, presents to you with so-called blackouts or faints, think about cardiac causes first or vasovagal attacks rather than a neurological cause. This is a third case, a 20-year-old right-handed female college student who had normal developmental history during childhood. She was above average at school in terms of IQ and intelligence. At 8 years old, she started to have what was thought to be night terrors, mengigau in Malay. They occurred every night and at times several times a night. The duration of each attack, usually about 30 to 45 seconds, sometimes to a minute. And then she would be immediately responsive and orientated after the event. She complained that she was unaware of the events, although she knew something had happened, and she was on 3 anti-epileptic drugs, which she took religiously, and she had normal physical examination. So this is one attack we recorded in the lab. This is infrared camera again. You will see in a minute. She will. A few seconds. She will scream. Vocalization. Thrashing about. That's about 35 seconds of the attack, 30 seconds maybe. And she would sit up, recognize her sister on the left of her, and she knows roughly where she is, what time of the day, or rather night at that time. And she knew that something had happened. So this she recovers almost immediately. So this was thought to be night terrors or Monigao. And some people thought this was pseudo-seizures, but remember this was at night, which is unusual for pseudo-seizures. And every night of her life from the age of 12 to 20, when this recording was done. So was that an epileptic seizure? Just think about that. So what we did was, the brain scan was normal from elsewhere. We repeated the brain MRI on a 3 Tesla magnet. And if you look here, the top right panel here, I'm just waving my arrow here. You can see this hyper intense serpiginous lesion and the very blur gray-white junction. And on the sagittal view T1 weighted, you can see this hypo-intense lesion, or iso-intense rather, in the frontal lobe. And histologically, this was removed. We planned this with the surgeon, and she had focal cortical dysplasia. And from the day of the operation until today, which is like 15 years later, she is completely seizure-free. So what she had were frontal lobe seizures. Now these attacks are very brief attacks, and they're commonly nocturnal, like in her case. So you get nocturnal seizures like this, you must think of frontal lobe seizures. The post-ictal confusion is usually minimal or none, right? And because it's located in the frontal lobe, the motor manifestations become prominent, like in her case. So they may be tonic, stiffening, or postural, they have some funny posture, and they're often hyperkinetic, as in this case, and vocalization is common. The automatisms, unlike temporal lobe epilepsy, tend to be bizarre and violent, and sometimes they have bicycling movements in bed, stepping, kicking, or if they're standing, they'll be circling, right, turning around in a circle. And often misdiagnosed as pseudo-seizures, as I mentioned earlier, and so sometimes it's also known as pseudo-seizures, right? So it's not a pseudo-seizure, and you thought it was. So that's why it's called pseudo-seizures. The fourth case is a 43-year-old right-handed surgeon who woke up from sleep 2 weeks prior to seeing us with continuous involuntary movements of the right foot. These movements persisted 24 hours a day, every day for the preceding 2 weeks, but he had preserved awareness. Because of the continuous movements of the foot, he couldn't walk without crutches, and he was otherwise in good health with no other medical problems. He consulted a private neurologist and who said that he had myoclonus and treated him with valproate, but there was no response. The brain CT was normal, and the brain MRI at 1.5 Tesla was also normal. This was discussed during the clinic visit to me. So this goes on and on. You can see it's very tiring. He becomes fatigued. He just couldn't stand it anymore. So this is when he was already on valproate. He's just jerking away. It's quite rhythmic. He's talking to me, okay, giving me the history. So was that an epileptic seizure? Think about that. Okay, so again, what we did was we repeated the scan on a 3 Tesla magnet, and we saw this on a flare coronal image of the brain. If you look at this, I'm just circling with my arrow here again. Hyperintense lesion, just maybe 1 to 1.5 cm in diameter, and you just can see it there, not very clear on the T2 weighted, right? This is focal encephalitis, actually. So we gave him IV methylprednisolone for 5 days, and he was basically cured without any more seizures from that day. Did not need any anti-epileptic drugs, and until today, which is like 10 years later, he is still seizure-free. So what he had were focal seizures without loss or impairment of awareness, previously known as simple partial seizures in the motor cortex. So in this seizure, in these seizures, there's no alteration in consciousness, there's no amnesia, the signs and symptoms are focal, the onset is sudden, the offset or cessation is also sudden, and it's always due to a focal cortical pathology. And if you do an MRI at a powerful magnet, you will find the pathology. The focal clinical features, as in this case, reflect the anatomical origin of the seizures. Right? So his was in the motor cortex, exactly where the right foot area was, if you remember the human homunculus. The EEG is often normal, whether you do it during the attack or between attacks. The EEG is often normal. And if these attacks are continuous, the terminology is epilepsia partialis continua, which is seldom used nowadays. Case 5, the last case, was a 28-year-old unemployed right-handed gentleman. He had attacks of what was reported as strange behavior starting at the age of 15. When he came to see us, he had these attacks at 2 to 3 times per month. He was on 3 medications. It starts with a feeling of angin in the stomach, he says. He would lose awareness, becomes unresponsive, with chewing movements of the mouth. His right fist becomes clenched, and he will gesture with his left hand. You'll see this in the video in a minute. These attacks would last up to 7 minutes sometimes, and then afterwards he become dazed and confused. He was admitted to the psychiatric ward in Hospital Bahagia, where he stayed for months until an uncle brought him to UiTM Medical Center for a second opinion. So this was one attack we recorded in our lab. He actually is blank now, unresponsive. His right hand actually is stiff already. And his left hand is, he gestures like this, like he's waving, is like twinkle, twinkle, little star, right? He's looking around, dazed. You can see the right hand coming up now in a clenched fist, right? And if you look closely at his mouth, he'll have chewing movements and then swallowing and also lip smacking. He's clutching onto the bed sheet with his right hand as well because it's stiff. It's holding onto tightly to the bed sheet. Now he has movements of his fingers, both sides eventually. Right? This will go on for 7 minutes, and I won't have time to show you the entire video, but he doesn't have any generalized tonic-clonic seizures. So a witness may think that this is just strange behavior. He's inspecting his fingers now, and would send him to a psychiatrist, which they did. Okay. So was this an epileptic seizure? It's probably easier for most of you. Yes. So these seizures are part of the disease or syndrome known as mesial temporal lobe epilepsy, or just temporal lobe epilepsy will do. They start off with a typical aura, and an aura is actually a focal aware seizure or simple partial seizure, the old terminology. They would have a rising epigastric sensation like going down a roller coaster. So some people will say sinking epigastric sensation. And in Malaysia, it's almost always angin. Or sometimes a special sensory aura, which is like, example, olfactory hallucination. Sometimes psychic phenomenon like deja vu or jamais vu. And autonomic phenomenon may occur. This is followed by a characteristic focal seizure with impaired awareness, previously known as complex partial seizure, in which they become blank, like this man here. Sometimes we use this word absence loosely because they will have a motor and speech arrest. And then the arm that is dystonic to the lesion becomes stiff or dystonic. So the arm which is contralateral to the lesion becomes dystonic. There will be automatisms. Usually it's oral elementary, as was in this case, chewing movements, lip smacking, swallowing, or motor automatisms like walking around aimlessly in the room, or manual automatisms where patients may rearrange things on the table or in the bedroom. There'll be these automatisms may last very long. Sometimes, usually it's more than 1 minute, but sometimes as long as a few days. Post-ictal confusion afterwards, and then the recovery is gradual. Sometimes they rub the nose with the ipsilateral hand, this hand which is ipsilateral with ipsilateral to the lesion. This is followed by amnesia. They can't remember what happened. So there are 4 A's here: aura, absence, automatism, and amnesia. So just remember that, typical of mesial temporal lobe epilepsy. Okay. So this man had a brain MRI. If you look at the top right panel, this is a T2 weighted coronal image. And I just, this in this box here, the left hippocampus is shrunken and brighter. This is a unrelated patient with autopsy. Hippocampus means seahorse. If you look at the seahorse on this side, on the left side, it is shrunken and paler. And then histologically, these are not from him. So the normal side full of neurons, sclerotic side devoid of neurons. Okay, I'm going to end this lecture with two tables, or one table with 2 pages, just to differentiate between tonic-clonic seizures, psychogenic non-epileptic seizures, and convulsive syncope. So the duration in a tonic-clonic seizure is seconds to up to about 2 minutes. Psychogenic non-epileptic seizures tends to be prolonged. Of course, convulsive syncope are very brief, less than 30 seconds usually. There's an aura in tonic-clonic seizures if it starts focal. It's very rare in psychogenic non-epileptic seizures. In convulsive syncope, as mentioned earlier, they become lightheaded, the vision going black, and maybe a sound in the ear. The eyes in a tonic-clonic seizure will roll up and almost always open. In psychogenic non-epileptic seizures, almost always closed. In convulsive syncope, can be open or closed. Jerking, of course, will occur in tonic-clonic seizures, first tonic, then clonic. In psychogenic non-epileptic seizures, it's irregular, non-rhythmic, waxes and wanes as mentioned, and they're not stereotyped. It depends on the audience, the type of audience. In convulsive syncope, it's often present, right? And maybe tonic only, and it's usually brief. So be careful, that may confuse you with a tonic-clonic seizure. Tonic-clonic seizures can occur anytime, and often in sleep. Psychogenic non-epileptic seizures rarely occur in sleep. Convulsive syncope, of course not. They must be standing, sitting, or walking. In tonic-clonic seizures, they often have injury, and sometimes head injury, quite severe. In psychogenic non-epileptic seizures, this is rare, of course. They were planned therefore. And in convulsive syncope, sometimes. Depends where they are. In terms of vocalization, there may be an epileptic cry in tonic-clonic seizures. Psychogenic seizures, usually no. Convulsive syncope, it's rare to get vocalization. Similarly, pelvic movements is classic of psychogenic non-epileptic seizures. It almost never occurs in tonic-clonic seizures, and of course, no in convulsive syncope. Incontinence is common in tonic-clonic seizures, sometimes in convulsive syncope, usually no in psychogenic non-epileptic seizures. Attacks are often daily in tonic-clonic seizures, sometimes in psychogenic non-epileptic seizures, almost never occur daily in convulsive syncope, of course. Crying during an attack, no in tonic-clonic seizures, psychogenic seizures often, and convulsive syncope also no. Post-epileptic drowsiness can last for hours and up to 72 hours in tonic-clonic seizures. Psychogenic seizures no, and very brief or do not occur in convulsive syncope. So in conclusion, ladies and gentlemen, if seizures are not stereotyped, think about psychogenic non-epileptic seizures. But if they are, it can be anything. Even syncope can be a stereotype. The diagnosis of epilepsy nowadays requires occurrence of 2 or more provoked and unprovoked epileptic seizures separated by more than 24 hours. Okay? Vasovagal attacks are the commonest cause of blackouts in the absence of focal neurological signs. And do not start an anticonvulsant, anti-epileptic drug to test the diagnosis of epilepsy. That's wrong. EEG is never a substitute for a detailed clinical description of the attack or video recording. You must get a good history. Okay, thank you very much for your attention.
All right, thank you very much, Professor Raymond, for that very informative session. So Professor Raymond will now be taking questions that is in the chat box. The attendees are also free to ask your questions live, so you can unmute yourself and turn on the video. I pass the floor to you, Professor Raymond.
All right, Q&A, it's, it's in the chat box, right? So the first one is from your COO. Not question, but thank you very much for the talk. You're welcome, sir. Right, then this one. Kindly type your question, okay. Cerebellar fits or cerebellar seizures present with paroxysmal loss of consciousness and non-stereotype movements. Are these classified as epileptic seizures or pseudo-seizures? Okay, seizures must come from the cerebral cortex. if they originate elsewhere, they are not epileptic seizures. I mean, seizures, it's the Greek word that means seize or attack. So if you just say seizures, you know, even a simple faint is a seizure, if you like. But epileptic seizures must come from the cerebral cortex. So if you have cerebellar movement disorders, then it is not classified as an epileptic seizure. The treatment is, of course, totally different. The classical anti-seizure drugs will not work. You probably need to treat the underlying cause. So it's probably a misnomer to say cerebellar seizures. It might confuse the patient. So patients might think they have epilepsy, and then they get labeled and cannot drive, cannot swim, cannot get married, and so on. So probably best to avoid the term cerebellar fits or cerebellar seizures. So that's, I hope I answered that question, the first one. Okay, yeah, and they present with non-epileptiform discharges on EEG. That's right, yeah. So they don't have the classical epileptic discharges, spikes and waves, or spikes or sharp waves. So they are not epileptic. Okay, so it's not to be confused with that. Paul Hubbard, individuals with schizophrenia at increased risk of developing epileptic seizures. True. What are the links between the types of seizures they get and those that individuals with schizophrenia get, I suppose? And can this provide any insights into treating these diseases? Okay, so we take, that's right, yeah. In fact, my colleague, when I was at Queen Square, London, doing epilepsy training, Mike Trimble, I don't know whether Prof. Paul Hubbard knows him. He's the famous psychiatrist who spoke about the relationship between psychosis and epilepsy. There's a theory that when the psychosis gets worse, epilepsy gets better, epilepsy gets worse, psychosis improves. And it's also post-ictal psychosis. So it's a bit of overlap. But you're right, patients with existing psychosis, particularly schizophrenia, have an increased risk of seizures. I don't know why, I have no answer to that. And the treatment is going to be multidisciplinary, going to be combined. So I treat patients like that with a psychiatrist. In fact, that girl with if you remember the hyperkinetic seizures that occurred every night at 2 a.m., and then she becomes hyperkinetic, and everyone thought it was pseudo-seizures. She also had a psychiatric problem. She was seeing a psychiatrist, and I was treating her with a psychiatrist. She was hypersexual, actually, because it occurred in the frontal lobe. She had disinhibition. She used to send me all these sexy messages, which I ignored, and then she suddenly went to the surgeon. It was funny. And then, so that happens. So we frequently treat patients with psychosis, existing psychosis with a psychiatrist. And we must be careful. Some drugs are epileptogenic. So we try to avoid those drugs. But sometimes you can't. You just have to give both the neuroleptics plus or the antipsychotics plus the anti-seizure drugs. Good question. I'm always aware of that, and so are the psychiatrists. They get worried when they label someone psychiatric, but it actually are frontal lobe seizures. Of course, I think the psychiatrists will know the difference is that in epilepsy, the attacks are interspersed with periods of contact with reality, with the real world, whereas in psychiatric illnesses, it's constantly, they don't have a contact in the real world or to the real world. So it's difficult. We can discuss this further. Good question, yeah. Michelle, for Houseman, how often do we see these pseudo-seizures? It's quite often in Malaysia. If you speak, again, this has to be managed with the psychiatrist. Usually the conversion disorders we manage with psychiatrists, so do the malingerers, yeah? The malingerers are more difficult. The one that I showed you, the man, he was malingering. It was difficult. He just ran away and sought another neurologist opinion. But of course, we all know each other in Malaysia. So every neurologist that sees him will ask me, who is this guy? And eventually, so I don't know where he is now. But you are right. This question is good. Pseudo-seizures are common, and they're commoner in countries which are developing or underdeveloped, actually. So I spoke to psychiatrists from Australia and the UK. It's getting less common in developed countries. It is still common here, not just pseudo-seizures, but pseudo-blindness, pseudo-coma. I've seen all of this. And most of the pseudo behaviors are in neurology. Yeah? Seldom they get pseudo-chest pain and angina, but mostly come to us neurologists. So that's why I started the lecture with that first video to show all of you, medical students and house officers, how to differentiate the two, right? We don't want to label patients having epilepsy and then give them 4 or 5 drugs. They take them unnecessarily, give them a label, they become sidelined in society. So that's not good. So I hope that helped a lot, yeah? How the exact frequency, I don't know. But in epilepsy patients, in real epilepsy patients, the prevalence of pseudo-seizures, concomitant pseudo-seizures, about 30%. And then I did a study while in the second time I went to London. We looked the other way. So we looked at pseudo-seizures. How many times did we have to record the pseudo-seizures to get one real one? And we found that we needed about 7 recordings in the lab. And that happened in about 15% of patients. So I just repeat this. Epilepsy patients have a 30% prevalence of concomitant pseudo-seizures. But if you start with pseudo-seizures, there's a 15% chance of them having real epilepsy, yeah? So those are the figures that came out of the second one, especially 15% from our study. It's published in the journal called Epileptic Disorders back in 97, I think. So that's quite a long time ago. If a HO thinks he is seeing a patient having a seizure, what should his thought process be? Like, what should he think or do? Epileptic seizures, if there's an attack in front of you, right, the first thing you do is not to panic, right? And it's a medical emergency. You start timing, yeah? Timing first. Take a watch, look at the clock in the emergency department or in the ward or wherever you are in public. Look at the time, because the time is not so important. It's something made important by the International League Against Epilepsy. You want to time it because after 5 minutes and if the seizure still continues, it's now classified as status epilepticus. It is mandatory to bring the patient to the closest hospital, because that's when neurons start to die. 5 minutes, okay? So, but most seizures will end within 2 or 3 minutes, right? So rest assured, then what you do is you wait for that to finish, right? And then you can interview the patient, and once he's recovered, have you taken your medication? Do you know you have epilepsy? If they do, just send them home and ask them to take back the medications. That will solve the problem. If they don't, that means the first attack, better bring to hospital anyway. Or if there's a obvious head injury in a non-epileptic as well, I have to bring them to hospital, especially if you see brain coming out from a fracture, you have to bring them to hospital. Just going back to the emergency treatment, if you see this in the public place, loosen the collar if they're wearing a tie or the top button is buttoned up. Remove dangerous objects, hot things like a heater next to the patient. It's easier to move the objects than to move a heavy patient and then injure yourself, and then you cannot look after the patient. Do not restrain the patient from jerking, or do not insert object into the mouth to prevent them biting the tongue. That's dangerous because that object may break and the patient may aspirate that into the lung, and you are going to obstruct the airway anyway. So wait until that's over. Then you roll the patient to his left probably, but right is okay. But left if you can. I mean, if you roll to the left and the left is a big drain, you can't see the patient's face. So no point rolling the patient away from you. Just towards you, yeah, towards your face. And then just make sure the airway is clear and nothing blocking the airway. And then clear the crowd. People like to crowd around a seizing patient. They're forming what I call a carbon dioxide tent. But pick one clever looking person and make that person stay with you, so you have help. That person can help call an ambulance and so on. So don't get rid of everyone. You must have somebody to help you, 1 or 2 other people, right? So that's my answer to that question. What is pseudo-seizure? The proper treatment for pseudo-seizures. This is Farah Nisa. I hope I haven't missed anything. From what I understand, these seizures are what? Okay, correct me if I'm wrong. You are wrong, because the what one is actually malingering, right? What I call mengadaitis. And what can we do to treat or advise if they keep on coming with seizures? Okay, so the one which is what making it up, I mean, they're aware that making it up, I'll give them a tight slap. No, I'm just joking. We have to treat them again with sympathy. There must be something that they're seeking. Usually it's attention seeking. The conversion disorders need real serious treatment by the psychiatrist, plus or minus the psychologist. Yeah, there's something going on there. And I normally let them reveal all their history, confide in one person, the psychiatrist. I don't want to know all your problems. So that was this conversion disorder. They are not what? They don't know that their seizures are not epileptic, okay? They're having attacks. But so what I tell them that your attacks are real, but they're not epileptic attacks. If you say that you're making it up, that's bad. You're going to reinforce the organicity, the false organicity of that problem. Do not reinforce that. Do not say you what, okay? We always sympathize with them and say that to you, these attacks are real, but they're not epileptic, and the treatment is, so and so. So that's the treatment for pseudo-seizures. And then we withdraw the medication slowly. So 4 or 5 drugs. If you find that the blood levels are 0, no need to think about withdrawing, because some of them don't take the medications in the first place, especially the what ones, the malingerers. But if they're on drugs, better withdraw them slowly, and then co-manage with the psychiatrist. Can I ask if serum prolactin, this is a GAP-T, serum prolactin levels, is it useful to support the diagnosis of psychogenic seizures? Okay, now I try to avoid the word psychogenic seizures. In fact, the International League Against Epilepsy has asked us to avoid that, because as you know, even true epileptic seizures can also be psychogenic, meaning that they can be precipitated by emotional stress. So we try to avoid that. You can use it, but try to avoid that in front of patients. And I don't use it with my students nowadays because it might confuse them. So it's better. The accepted terminology is in the ILAE is non-epileptic attack disorder, NEAD, which I find that is a mouthful, or just say non-epileptic seizures, NES. I use pseudo-seizures loosely because this is attended by medical people. Again, you don't use pseudo-seizures in front of patients. The serum prolactin has gone out of favor because you have to take the blood within 20 minutes of the seizure, which sometimes is impossible because you're not there, or not unwitnessed, or it occurs at night. And then you send for the lab and it comes back much later. That's the first thing. The second thing is that not all seizures would raise the prolactin levels, only generalized tonic-clonic and some focal unaware seizures previously known as complex partial seizures. The simple partial seizures or focal aware seizures, like the professor with the jerking of the right foot, no elevation of prolactin levels. So it's rather unreliable. But if you don't have access to a video EEG equipment like I do, and a lot of neurologists do, then of course serum prolactin will be a supporting result, a blood test that you can do, but make sure you do it within 20 minutes. So if you see a generalized tonic-clonic seizure, right, if you take the blood within 20 minutes, if it's negative, it doesn't rule out that. But if it's raised, I can bet you that it's going to be a real generalized tonic-clonic seizure. But those are easier because you don't even need a prolactin level, especially if you saw cyanosis and there was a prolonged post-ictal phase. Provided you don't give IV diazepam, then it's almost certainly a true epileptic generalized tonic-clonic seizure. Okay, I hope I answered that question. Pseudo-seizures, this Amira, can they drive home or personal vehicles? How to tackle this prickly issue? So pseudo-seizures, surprisingly, they don't have attacks while driving, right? I have not seen one at all because they are in control, right? These attacks, even the conversion disorders, they don't have attacks during while operating heavy machinery or driving a vehicle or on a bicycle, riding a bicycle. It doesn't happen. Firstly, they may not have an audience, but more importantly, they know they have to get to somewhere from point A to point B. They don't have that seizure, right? So, in even a DVLC in the UK and JPJ in Malaysia, pseudo-seizures are not mentioned. It's up to us. But of course, if you have not made the diagnosis and you've labeled it epilepsy, they're not supposed to drive, right? Which is fine because you're not sure yet. So you get a neurologist to see once we have diagnosed that. I would still caution though, because I want to rule out, as I said, whether they have true epileptic seizures after recording several times. Just a bit, be careful about that. So, but by right, yes, they can drive if they are truly, pseudo-seizures 100%. Yeah. Where are we now? This is now Farah Nisa again. I've seen videos on people diagnosed with Tourette's, where this one particular person has seizures, absence, blah, blah, blah. How common is it for people with Tourette's to develop seizures, or is it a package thing where people with Tourette's will get seizures one day? I don't think so. I don't think so. Tourette's is not my area. Usually we get psychiatrists to manage this, or a movement disorder specialist. I'm an epileptologist. So this Tourette's, as you know, is more like tics. I don't know whether there's an increased risk of true epileptic seizures, but be careful, yeah. These patients may actually have movements that mimic a seizure. I did have a video on this, someone with tics and was labeled as seizures, but actually he just had tics, not quite Tourette's, almost there, but it's a spectrum, as you know. Tourette's from being just small tics, right, like doing this with the head, right up to vocalization with what we call, what do you call it? No, with mentioning all four-letter words and so on. Coprolalia, that's the word for that, yeah. So I'm not sure about that. I don't think it's a package, but I have to see this video, Farah. If I can see that video, I will help you diagnose this. Paras, I like the HO 101. Okay, Paras, Dato Paras said this. HO seizure response 101. Yeah, agree with that. Muhammad Farhan, how many months should epilepsy patients have seizure free in order for them to be able to drive? Okay. In Malaysia, 1987, JPJ came up with what they call Akta Pengangkutan Jalan Raya, 1987, in which they stated that, very vaguely, if a doctor feels that you are not able to drive, and they put in brackets, including epilepsy, blah, 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 you're not allowed to drive. Full stop. I don't know what that means. Is it indefinitely or how long? In the UK, but sorry, then after that, there was a guideline that came out, 2002, much later, but it's only a guideline from the Ministry of Health, working with DOSH, working with, and also with some neurologists. I wasn't involved then, I don't know why, but they were not all epileptologists, so they set it at 2 years. So in the UK, it's now 1 year, right? So I use 1 year with my patients now. I ignore the, JPJ rule because it's like crazy, you know? And then JPJ called me up for a meeting about fitness to drive for neurological diseases, and one of it was epilepsy. And somehow JPJ has this illusion that drivers who have epilepsy and they drive heavy goods vehicles like buses, trucks, lorries, and so on, are able to drive after 15 years of seizure freedom with or without medication. I find that really bad because in the UK it's the opposite. If you drive heavy goods vehicle, no driving for life. If you drive a private vehicle, you can drive after 1 year of seizure freedom with or without medication. In Malaysia, it's totally opposite. Private vehicle, like, cannot drive for life. Heavy goods vehicle after 15 years. Don't you think this is like not really clever? Anyway, I lost the battle, and that's it, right? That's the rule. But to answer this question, it's 1 year. 1 year of seizure freedom, right? And then you are allowed to, with or without medication, you're allowed to drive. Swimming, yeah, swimming, actually you can swim, even if you have seizures, provided the caregiver is in the swimming pool with the patient, following the patient. Don't rely on the lifeguard, because I quip saying that the lifeguard may have absence seizures. That absence, that daydreaming by the lifeguard can cause death and drowning from the epilepsy patient. He thinks that you're fooling around and so on. So always have a caregiver with you, but preferably, yeah, don't swim. It's the best. And of course, do not operate heavy machinery. Firearms, yeah, the other one. What's the significance of mentioning the handedness in your patients earlier? Is it to categorize the type of seizures? Yeah. If someone's right-handed, right? If someone's right-handed, it's like a 95% chance that his dominant hemisphere, the language center, is on the left hemisphere. If someone is left-handed, however, it's 50-50, yeah? 50% chance that the language center is on the right or the left. So I'll give an example. If the lesion is in the right temporal lobe, so the right temporal lobe seizures, during an unaware focal seizure, the patient may be able to speak if he or she is right-handed, what we call ictal speech. This same right-handed person, if he or she has a focus on the left side, however, in the language center, then there is speech arrest, we call it. So they're talking halfway and they stop talking. So that's called a speech arrest because the epileptic focus is discharging and interfering with the speech, the language center, on the same side, okay? So I just to recapitulate this, if you're right-handed, you have a right hippocampal or temporal lobe lesion, you may be able to speak during an attack. You're right-handed and you have a lesion on the left, there will be speech arrest. Okay, so that helps. That helps us to localize. And why is it so important to localize? Because in this day and age, we can actually do surgery. I've not come to that, but we can remove that lesion, especially hippocampal sclerosis, and basically cure these patients. And when I was in UiTM, we started this epilepsy surgery program. Sorry, I'm diverging a bit, but just to tell you, this is important because Malaysia now has overtaken Singapore in terms of the performance of epilepsy surgery on epilepsy patients. We've superseded them. In fact, they are asking for cases from Malaysia, of course, sent to UiTM or now. After UiTM in 1997 was the first case we operated, and then followed by UMMC and then by HUSM. And then, of course, HKL and other places now are doing it as well. But surgery is the only way to cure epilepsy. Yeah? I use the word cure loosely because really you can't cure. It's long-term remission, lifelong remission if you like. So I would like to call it cure in my lectures. Yeah. Do you have, Jawed, do you have any experience in follow-up of patients in the treatment of refractive seizure with vagal nerve stimulation? Yes, of course, yeah, I do. I think we're coming to the end of the Q&A, so this probably is the last one. We in Malaysia, I think there have been about almost 50 cases, epilepsy patients who have had VNS, vagal nerve stimulation. You know, in America is the algorithm is totally different for the management. Number one is look for a lesion to operate. So surgery first before pharmacological treatment. Number two, vagal nerve stimulation. Number three, long-term anti-seizure drug. In Malaysia, we tend to follow the British Australian style, which is to start treatment with medicine, wait for 1 or 2 years after maximum doses of, optimal doses of 2 medications as well, then we refer for surgery. If you cannot find a lesion to operate, vagal nerve stimulation, okay? So I think maybe I have to end here. It's 11:59 on my clock. Farah, back to you.
All right. Thank you so much, Prof. Raymond, for that very excellent Q&A session. I guess that's the question for today. So I am sure the participants will be leaving the session today with a much clearer understanding on seizures and epilepsy. Once again, thank you very much, Prof. All right.
Thank
Dear
you.
delegate. All right.
Thank you very much for inviting me. Yeah, and thanks, Paul Hubbard.
Yeah, he's our acting CEO here and
Okay,
the Dean of our Academic Affairs.
Right.
Yeah.
Thanks, Paul.
All right, so dear delegates, thank you very much, and I hope you have found that session informative. We have now come to the end of our session. Take care and stay safe wherever you are. Goodbye.
I can see Paul now. Right. Thanks for inviting me. Great.
Thank you very much. Yeah, thank you very much for a very good talk. Really enjoyed it. And I'm a
all the
neuroscientist
best.
as well, so that's really good.
Okay, we can do it some more later. Another
Excellent.
session.
Thank you.
Right. Bye-bye. Bye-bye.